So good afternoon to all the psychiatry delegates of the nation. We are highly obliged to have you all this afternoon with us of our new webinar series, the Experts Forum. I am Paras Doshi, Assistant Marketing Manager, Arkin Laboratories. The Experts Forum is an exclusive webinar series in which we will discuss about various aspects of country's newly launched antipsychotic, which is Cariprazine, and our newly launched brand of Cariprazine, which is Carilift. The experts forum will help to resolve all the queries related to molecule, its usage in schizophrenia and bipolar disorder, and understand how well we can advance the psychosis management therapy to uplift the quality of life of our patient. Today with us, we have one of our prominent speakers of the country, Dr. Amrit Pattojoshi from Bhubaneswar, Odisha, who will be sharing his experience with cariprazine as a molecule and how it has been and helping to his patients in recovering up from negative symptoms of schizophrenia. Post session, a short Q&A session will be conducted, which can further help all the delegates to have a clear picture. So just to tell you a few words of Dr. Amrit Pattojoshi, no doubt we don't need any introduction, but still, Dr. Amrit Pattojoshi needs to have no new introduction. He is a leading psychiatrist from Bhubaneswar who is specialized in overall mental health with key skill areas in mood disorder, anxiety substance, child psychiatry, as well as sexual disorders. Dr. Pattojoshi was also an organizing secretary for the 74th Annual National Conference of Indian Psychiatry Society, NSIPS Bhubaneswar, which was held in this February in this particular year. And I'm sure we all must have witnessed, we have come across him several times. With impeccable experience in psychiatry and de-addiction medicine, Dr. Pattojoshi's name figures among the top mental health practitioners in the state, not only in the state, but inter India. With this short introduction and no intention of keeping you all awaited for this exciting session, I would like to hand over this session and this platform to Dr. Amrit Pattojoshi. Dr. Amrit Pattojoshi, over to you.
Thank you so much for the kind introduction. I'm no top psychiatrist. I'm like as anybody else. Maybe with time, with age, with you have little more patience than your average friends, but then it's all similar. We see the similar kind of thing. So let me share my screen if I'm permitted by the host. Shall I share my screen?
Please, yes, sir, I guess you can share it.
Thank you so much. Thank you. So as practitioners, we are always in the lookout for something that gives us that extra mile, that extra millimeter, that extra centimeter, whatever you term it as. But when we are practicing, when we see patients coming back, telling us that these are the symptoms that have not improved, these are things I need improvement. I'm better, sir, but can I call this that I am better? So then we start thinking, if you look at psychosis, if you look at bipolarity, there are certain areas where we always are thinking in terms of armaments. When the pharma people come to us, they tell us, what do you want? What do you need? It's not just that they tell us what they need, but sometimes, many times they come and ask us. So one of the common things which I, as a practitioner, and I have been in psychiatry for the last 20 years, would always talk about negative symptoms. Because negative symptoms, you are trying to give a lot of antipsychotics. You have to understand what is negative symptoms again. And now I'll tell you the primary negative symptoms, the secondary negative symptoms. The negative symptoms which secondary to the positive symptoms. You get negative symptoms of either if the patient is depressed, anxious, or maybe side effects of antipsychotic. So many times what happens is the patient has negative symptoms and you pump on antipsychotics. And secondary to the antipsychotic use, we the negative symptoms sometimes exacerbate. So that is a very, very tough call for us. And I think cariprazine is something which has tried to fill in the gap. And as my presentation goes on, and I'm speaking on this molecule not because of some pharma company has told me, because I'm convinced about the molecule. I'm not somebody who will come and just speak about anything. Something which I have used, something I'm convinced about, something I think which will help you. Because at the end of the day, if your patients are better, if your clients are happy, you are a successful doctor. Rest all does not matter. Even if you see 5 patients and think about them properly, use proper molecules, give them the proper treatment, I think you are the best possible doctor in the state or in the country. That's what is important. Now coming to cariprazine, if you look at the whole population of India, around 1 to 2% of the population the Indian population suffer from severe mental disorders such as schizophrenia and bipolar disorder. And if you look at schizophrenia in India, 3.5 million people had schizophrenia in India. That is prevalence of around 0.3%. And I think because of the treatment gap, health seeking behavior is very, very low in India. I think it's around 1%. So maybe around 8 to 9 million people have schizophrenia in India, and that's not less. If you look at the current unmet needs, we always look at unmet needs. Challenge of current antipsychotics for controlling negative symptoms. That's what I was talking about. The important metabolic side effects of commonly used antipsychotics. If you talk about olanzapine, if you talk about clozapine, if you talk about risperidone, if you look at quetiapine, look at the atypical antipsychotics or the second generation, as you might term them as, you have a lot of metabolic side effects, and that is very worrisome. If you look at diabetes, if you look at hypertension, if you look at obesity, if you look at hypercholesterolemia, there's on the rise. Get people at 45, 50 complaining of diabetes. We have 35-year-old now complaining of diabetes. So naturally, the age is reducing. And if you're giving something which exacerbates the things which are naturally also almost on an epidemic basis, you have cause of concern. So metabolic side effects are very, very important. And treatment adherence is very important. You prescribe, the patient takes the prescription, buys medicines, whether he eats, whether he buys the medicines, whether he comes for follow-up. The treatment adherence is a very, very important aspect in a practice. So difficulties in controlling negative symptoms is currently the most important unmet need in schizophrenia. And I accept and I acknowledge that this is the most important thing. So negative symptoms in schizophrenia, how to recognize and manage them is very important. They are related to all three domains of schizophrenia. If you look at emotions, if you look at cognition, if you look at behavior, and they include avolition, alogia, anhedonia, affective flattening, as well as asociality. If you look at the 4 A's or 5 A's of Boiler, these no. So anhedonia, inability to experience pleasure; avolition, lack of energy, and a seemingly absence of interest in routine activities; asociality, severe impairment in social relationships; alogia, a negative thought disorder occurring with poverty of speech and content. They'll be speaking much, much less. They're not able to experience pleasure. They will have lack of energy. Social relationships, they are not able to do, and affective flattening, markedly decreased emotional response to a stimuli. You give them good news, they won't respond. You give them a bad news, they won't respond. So these are the characteristics which actually define what are the negative symptoms in schizophrenia. So how to recognize and manage them actually? They may appear early during the course of illness, generally during the prodrome phase, and related deficiencies persist when schizophrenia progress. So they start with negative symptoms and might progress or persist with the onset and the progress of the disease. And positive symptoms might also occur together. To correctly diagnose primary negative symptoms, it is essentially to rule out the presence of other mental conditions, including mental retardation. It's very important, talk about the developmental history of the individual. You talk about dementia, which is which comes later on in life. Depression is very, very important because if you look at the core symptoms in terms of inability to experience pleasure, lack of energy, negative thought disorder, this all might be part of the depressive symptoms. But if you look at depression, if you look at schizophrenia, the major issue is that of mood. When you look at depression, if it is severely depressed, somebody might have, affective flattening. But initially, in the initial part of the illness, the patient will always talk about his mood. He's depressed. He does not feel good. He feels low. He feels like crying. Generally, in case of schizophrenia, there is affective flattening. Even if you ask what is the mood, it's okay. Even if you give them a stimulus, there's no response to the stimulus or minimally response to stimulus. That is how and if you look at the, how the symptoms have evolved over the course of time, you can understand that this is schizophrenia and not depression. You also have to look at anxiety, where there is a preoccupation with what might happen. Substance misuse is very important, but the very, very important thing is once the substance is taken out of the body, the patient comes back to normal, paranoia, etc. So these are very important issues.
Yeah, अभिमन्यु से बात हुई आपकी?
Now, current options to treat schizophrenia are first and second generation antipsychotics that mostly improve positive symptoms, but generally do not significantly ameliorate the cognitive functioning and negative symptoms. Even after psychotic symptoms are well controlled and general functioning is restored, neurocognition negative symptoms must be managed as effectively as possible in order to achieve full outcomes as desired. However, despite the availability of treatments having statistically significant effects on negative symptoms in meta-analysis, the average improvement is probably too small to be clinically meaningful. So people talk about meta-analysis, people talk about molecules. But we as clinicians need to take it with a pinch of salt. Like until and unless I am not convinced about a molecule and I use new molecules, I will not use it on a regular basis. Neither will I talk about those molecules. So challenges of current antipsychotics for controlling negative symptoms. Negative symptoms lead to a significant burden and deterioration of the quality of life in patients with schizophrenia. We all know that. They're a core component of schizophrenia and they account for a large part of the long-term morbidity and poor functional outcome in patients with these disorders. If you have positive symptoms, they come early to your for treatment, and they get treated, they improve and they go back. Negative symptoms, maybe by the time they come to you, it's already 4 to 5 years have already passed. So they have poorer outcomes in terms, because if you look at duration of untreated psychosis, when it comes to negative symptoms, duration of DUP is much, much higher. They are associated with significant deficiencies in motivation, communication, affect, and social functioning. Negative symptoms are a multifaceted concept with dimensions that may have different impact on functional outcomes. Up to 60% of patients with schizophrenia have prominent or predominant negative symptoms that are clinically relevant and need treatment, and that's a huge number. Most of the available antipsychotics fails in controlling negative symptoms. Weight gain is very, very important metabolic side effect. If you look at, from baseline to maximum, most of the antipsychotics have significant or cause significant weight gain. All the routinely used antipsychotics such as haloperidol, risperidone, clozapine, olanzapine cause weight gain. And the weight gain with olanzapine, clozapine is around 5 to 6 kilos in 3 months. So that's huge. Data from the clinical antipsychotic trials of intervention effectiveness, that is the CATI study, showed that 70%, 4% of patients are discontinued medications within 18 months due to insufficient efficacy, intolerable side effect, of other reasons. So if you look at insufficient efficacy, most of the negative symptoms, most of the molecules that are used for negative symptoms are not very efficacious. Intolerable side effects, maybe sedation, maybe EPS, maybe weight gain, maybe diabetes, anything. Those are the major issues which you face, or for some other reasons. Not adherence to medication has a negative impact on the course of illness, resulting in relapse, rehospitalization, longer time to remission, and attempt suicide. I mean, many times people end their life. So cariprazine, how is it? Approved indication, treatment of schizophrenia, acute treatment of manic or mixed episodes associated with bipolar disorder. These are 2 indications of cariprazine. So generally dosage, form and strength, capsules come in the form of 1.5 milligram, 3 milligram, 4.5 milligram, and 6 milligram. In schizophrenia, you can start with 1.5 milligram, go up to 6 milligram. Bipolar mania, again, 1.5 milligram to 3 to 6 milligram. Depending upon clinical response and tolerability, further dose adjustments can be made in 1.5 milligram or 3 milligram increments in less than 2 days. So it's very, very easy. You can easily, hike the doses, and it can be administered once daily with or without food. It can be taken before food, with food, after food. So that's a very good thing. Mode of action is very important. It's a partial agonist at the D2 and D3 receptors with significantly greater affinity for D3 receptors, which are responsible for the negative symptoms. It exerts partial agonism at 5-HT1A receptor, antagonism at 5-HT2A and 5-HT2B receptors, and minimal antagonism at the 5-HT2C, 5-HT7 and H1 receptors. So weight gain is much less. So positive symptoms, the mesolimbic system is responsible for the positive symptoms. It is attributed to increased dopamine in the mesolimbic system, high dopamine release, overstimulated D2 receptors in the limbic system. So cariprazine blocks the D2 receptors, reduces the dopamine level, and you have the positive symptom that improves. Simple, not very tough. Negative symptom, that's the most important thing. In schizophrenia, if you look at the panel B, panel A is the healthy condition, panel B is the pathological condition. In schizophrenia, panel B, as compared to the healthy condition, the overexpression of the D3 Rs located in the DA neuron projecting from the VTA to the cortex leads to inhibition of dopamine release in the prefrontal cortex. So what is happening is, in the prefrontal cortex, the dopamine release is less. So D3 antagonism in the VTA can increase the dopamine neurotransmission to the prefrontal cortex. Now, once there is antagonism at the VTA level, it increases the dopamine neurotransmission to the prefrontal cortex, reversing the hypodynamic. So we had a hypodopaminergic functioning in the prefrontal cortex. So now what happens? More dopamine is released. So the negative symptoms improve and the mood improves. So if you look at the clinical trials, cariprazine versus risperidone in negative symptoms. So it was a randomized double-blind phase 3B trial. 461 patients were randomized to 230 for cariprazine and 231 for risperidone. Primary outcome was changed from baseline to week 26 or end of treatment on the positive and negative symptom scale factor score for negative symptoms. So we had the PANSS. So this was the improvement we saw. If you look, use of cariprazine led to a greater chance in panaceous affection from baseline to week 26 than risperidone. So if you look at risperidone, it's second generation antipsychotic, and cariprazine, we had a better improvement when it came to cariprazine. Now, if you look at the personal social performance scale, again, greater change in risperidone. So there was better improvement in the personal and social performance scale when it comes to cariprazine. Treatment emergent side effects, that is another major cause of worry for us. It is insomnia, akathisia, worsening of schizophrenia, headache, anxiety were reported in 54% treated with cariprazine and 57% patients treated with risperidone. Risperidone, if you look at risperidone, except for the akathisia part, a little bit of EPS part, rest all we have a good side effect profile. And I think if cariprazine is better than risperidone in the side effect profile, it is worth thinking about. Cariprazine in acute schizophrenia. We're talking about 3 studies. We had a Durgam study, we had a Durgam 2015 study, and a study by Kane et al. So if you look at the studies, it is based on the dosages. So cariprazine 4.5 milligram, cariprazine 6 milligram, cariprazine 6 milligram at the best improvement. If you look at the total change in the panaceous trial. Now, primary efficacy outcome. If you look at both these trials, there's increased response in the Durgam 2014 trial, that is 67%, and in the later on study, it is 51% and 52% when it comes to Kane study. So it is a placebo. It is a comparison with placebo. So that's significant. This is a significant improvement. The effect of cariprazine on the primary efficacy score was 50 to 67% greater than placebo. That's beautiful. The secondary efficacy outcomes. Look at proportion of patients with improved CGI scale scores after 6 weeks in the subgroup of severely extremely ill patients at baseline. And again, that was, if you look at placebo, if you look at cariprazine, 42% versus 74%, 18% versus 42%. That's also significant. In subgroup of severely extremely ill patients, cariprazine reduced disease severity in 74%, and 42% of them shifted from the severely extremely ill category to the mildly ill, borderline or normal state, and that is huge. If you look at the most of the resistant cases of schizophrenia, they are primarily due to the negative symptoms, and if you are able to make improvement 50% of them, I think that's even if you take it with a pinch of salt, even if it is 25%, it's something that is very, very acceptable, and that should be appreciated. Safety outcomes, very, very important. Whatever good they do, they should not do any bad. That's what we have been taught. Even if you are not able to do any good to your patients, I think you should not do any bad to your patients. And safety outcomes of whatever molecules we use, and when it is a new molecule, are very important questions that should crop up in our mind, and that should be addressed before we think of using a drug, any drug. The incident of treatment emergent adverse effects versus placebo's similar cariprazine 1.5 to 3 milligram per day and higher for cariprazine. So if you look at 1.5 to 3 milligram, they are similar to placebo. But if you look at 4.5 to 6, there might be, once you hike the doses, you should be ready for some side effects. There's a dose response relationship for akathisia. I think akathisia is one of the most common things that comes with cariprazine. That's my clinical experience. EPS is also not very common, but not uncommon also. And a little bit of postural hypotension is one thing we should be careful about. And some laboratory parameters like creatine phosphokinase and transaminase levels, mild elevations. So cariprazine appears to have favorable NNH numbers needed to harm values than some of the other agents, especially in weight gain and somnolence. And that is very important. So to conclude, cariprazine represents a good therapeutic option since it is beneficial in improving negative symptoms in both the acute and long-term settings. In addition, cariprazine can effectively control positive symptoms and reduce the frequency of relapse, thus suggesting that it can be used as a first-line therapy. Its unique pharmacological profile based on high affinity on the D2 and especially on the D3 receptors, partial D-agonist activity and low absent affinity for histaminergic and cholinergic receptors may contribute to the observed efficacy for negative symptoms and low rates of adverse events, including the important metabolic and cardiac side effects. Long combined half-life of cariprazine and its active metabolites may further allow for a longer maintenance of the therapeutic blood levels during intermittent, partial, or even full non-adherence. Key advantages of cariprazine: it causes less weight gain, no significant increase in QTC. You can give it once a daily dosing. with or without food, absence of prolonged titration periods. Within 2 days, you can hike the doses. Minimal anticholinergic, adrenergic, histaminergic, metabolic, and prolactin-related side effects. And that's what differentiates it between risperidone and this. Risperidone, you have higher chances of prolactin, whereas in cases of cariprazine, it is little less effective in negative symptoms, but many antipsychotics fail. It is safer, it is not too expensive, it is effective. You can even on your ongoing, patients in schizophrenia, you can use it as an add-on and gradually take out the other drug once you are confident about cariprazine. So I would always recommend people to use it as an add-on in the initial stage. If you have patients on schizophrenia, and sometimes you have primary schizophrenic patients who have negative symptoms, you can start it as the single drug also. So you can use it both way. If somebody is on drug, add cariprazine, gradually take out the other drug. Or if somebody comes first time with negative symptoms, start cariprazine. Or if somebody is not able to tolerate a drug because of the adverse side effects, start using cariprazine. And there are no rocket science that you need to do this blood investigation, you have to hike like this. There are chances of sedation, not more than 3 to 4% complaint of sedation. Those are important things in this drug. And I think it's a wonderful drug if you want to add a new thing to your armament. It makes you a better clinician, a more effective clinician. You have happier clients, you have happier families, you have more effective and more productive people, because the cognitive effect is also significant when it comes to cariprazine. Thank you so much for your patient hearing.
Thank you. Thank you so much, Doctor. This was a truly inspiring session. I request the members to ask a few questions if you have any, the doctor. We have already received a couple of questions, sir. Question one is, what is the role of cariprazine in de-addiction treatment? You share some insights. So, yes.
Now, if you look at de-addiction, de-addiction is not something which is just, de-addiction means which drug. Somebody is on benzodiazepine, somebody is on alcohol, somebody is opioid, somebody is on cannabis, somebody is on inhalants. So de-addiction, you can, if somebody is having sex, a lot of people take drugs because they have negative symptoms. It's a type of coping. It's, the self-medication hypothesis of addiction. If you look at this, many of these schizophrenics take substance to make them feel more confident, to make them feel more social. So I think here cariprazine can be of effect. If you look at the mechanism of action, the D3, what it does, it improves the dopamine in the mesocortical system and the prefrontal cortex, so that the reward centers might improve, the patient might feel a little better. So somewhere we can be used if I think this drug might work.
Thank you, sir. Thank you. And the next question we have, how cariprazine is safe during pregnancy and lactation?
Again, if you look at what the current things are, with, most of the antipsychotic, I'll tell you now, if off the record, I want to say, I tell most of the drugs are safe. It's just that we are very, very careful. Now, when many people ask me, somebody is having negative schizophrenia and somebody is pregnant, will she be able to take care of the child if she's symptomatic? Will she be able to take care of herself? Will she be able to adhere to whatever is being told? She won't. Now, it's a catch-22 situation. I always tell to my clients, I always explain to them what are the advantages of you, because I don't, the obstetrician or the gynecologist only look at the fetus. They're very narrow. I have to look at the everything. I have to look at the person. The person is more important to me than she having a child. First of all, X is important. Then is the pregnant X, which is important. So as long as the drugs are used in lower, as long as the whole collective good is better, if somebody is able to take better care of herself, better care of the baby, I think that always works. As long as, it does not directly cause harm. Most of the drugs do not do that. So what is, many of us are very, very afraid of what will happen. So I always tell them, do routine, ultrasounds. We have latest technologies of ultrasound. Use double doses of folic acid. Use the lowest possible dose of drugs. And if possible, first trimester and third trimester, let us be a little low. Second trimester, we can just, manage the patient. So that's the whole principle of it. Because people talked of lithium doing this, do that. I have never seen lithium doing anything to any patient. So what the text talks about, what the literature talks about, and what is in reality are little different things. I think if somebody is very, very disorganized, very, very negative, I think we can try this drug, but at lower doses.
Any case that you came across wherein you have reduced the other antipsychotics and you have increased the dose of cariprazine and managed it, the patient is well
Don't ask,
managed?
don't ask me any case. I've used in hundreds of cases. That's why I'm speaking to you today in a very confident manner. And I don't speak like that without using a molecule. So I'm very confident about this molecule. Many times I'm not using clozapine. Initially, the only thing when it came to primary negative symptoms which are resistant to other drugs was clozapine. Now I think of cariprazine. C for cariprazine now, then I think of clozapine.
Correct. We have one more question from Dr. Mohit Kumar Shahi. Can we use this molecule for management of BPSD?
What?
Can we use this molecule for management of BPSD?
BPSD. Yeah. Listen, now BPSD, when we have this BPSD, generally what are the symptoms? Mostly they are positive. If you look at the BPSD literature, you have to look at carbamazepine, you have to look at, risperidone works well. We have aripiprazole that works well. We have quetiapine that works well. We have melatonin that works well. And cariprazine is something we can use when it is negative symptoms, or suppose somebody is having BPSD and is having a hypoactive delirium associated with it. We can use it. I think it's an armament which all of us need to use it in different contexts and then sit down together, discuss things, and then maybe put it to. Primarily, I've used it in negative symptoms. I've used in hundreds of patients. I've used it in bipolar with mixed results. I've used it in 3-4 patients of BPSD. Results awaited. Substance abuse, I've used when it is a comorbidity with schizophrenia. That's where I've used this.
Any more questions from the participants you would like to have? I guess most of the doubts the participants are clear. And thank you so much, sir. This session was actually very interesting and very informative to all of us. And the cariprazine, as many doctors have a doubt how to use it, where to use it, how can this molecule benefit in which different indications. I guess it is almost all clear now. And with your experience, sir, I'm sure that this information will help all the psychiatrists and the upcoming PG students of our country. So, moving
Sir,
ahead,
I'm sorry. Before we, sorry to disrupt, sir, but before we, come to the fag end of this, we would want you to choose one good question because we want to give them a small prize or a token of appreciation of asking a good question. So, what is it that one question out of the questions which are asked that you would like to choose, whom we can go and gratify that doctor out of all the questions?
I think I should get a reward for answering all the questions.
So that is for sure. That is immediate. But yeah, I mean, since there will be
The
PG
pregnancy
students.
question was good. The BPSD question was good.
Okay, sure. So we will choose that and we will gratify that person in terms of giving at least a good question and participating in this. Please continue,
We
Prasad.
had participants. I'm not able to see any participant.
Sir, that is behind. I mean, of course, here we have a complete backlist which comes. So this is a different platform.
How many
That is
participants were there?
so
so
we
that
have
our
more
net,
than 70 participants right now
we have close
attending.
to 70 participants.
And earlier we had almost 120 participants who were during the main course of session.
No, there were people who were watching.
Yes, sir.
Yes, yes, yes.
I thought I was speaking to a empty audience.
No,
Sir,
sir.
no, sir.
Because we have a backend complete list which comes. That's it.
So it's finished. Presentation is finished.
Yes, sir. Now he is just giving a small Prasad, a small thank you note. Prasad, please continue.
Thank you. Thank you so much, sir. And at the outset, I take this opportunity to thank Dr. Amrit Pattojoshi for sharing his expertise on this very important topic and making this complex subject simpler and useful one for all of us. I would also thank all the doctors who have joined us for this webinar, and I'm sure that you all would have benefited from the experience of our faculty. Healthcare for all is commitment at Alchem, and we solicit your continued support for our brand of Cariprazine Carilive. Our rich psychiatry portfolio also consists of Newsita, Newsita Plus, Newsita Lite, and Mini, while came OD and Solution, Donep M and Donep M4 and Donep. And yes, of course, Melzap MD and Melzap Pill. We look forward to continue the health collaboration with you all in serving the Indian society. So thank you again and have a great weekend.
Thank you, sir. Thank you so much. Thank you, doctor.
ठीक था presentation ठीक था ना नहीं चलेगा
Sir, yeah, it was very good. In fact, we will have the recording part also.